Hi,
Hi,
Hello.
Good evening.
good evening.
ciao Alberto, ciao, ti sentiamo
Ciao Giuseppe.
perfettamente.
Sorry for the video, but for me is a busy situation because I am in my office and the connection not so good. So I am
No problem.
there is a so, the society, your society, for these first meetings, and I am very glad for the organization and for the possibility for us to be connected for a lot of this meeting that I hope in the future comes more and more. And I want to thank also Giuseppe Porcellini because he's the first that tried these meetings. And for the SIOT, is a great honor because when we start our collaboration, now we apply all the ideas that we have during the your Congress. For this, for these reasons, is a great honor for me to start this meeting. My talking is only about the to thanks all the person, and I leave the talking to Giuseppe Porcellini and to the moderators, and I stay connected and I listen with you the meeting. Thank you for your disponibility. Thank you.
Thank you. Thank you, Dr. Momoli. And for me, on behalf of the Tunisian Society of Orthopedic Surgery, we are really happy to start this first step in our collaboration. And we will continue, I hope. It will be a fruitful collaboration in the future, I think. And for this, I would like to special thank to our ambassador in Italy, Dr. Muhammad Abdel Kafi, who played key role in moving this collaboration forward. And, uh, and yes, Muhammad Abdel Kafi is the key role. And now this webinar will be the first step, and we will continue together. It is a little bit like a couscous pizza webinar, and we will enjoy together this first webinar, and we will continue. I think that it will be also another webinar together with the Italian society and the Tunisian society. It will
Two
be
others.
about the worst cases of proximal femur fractures, I think. Is it like that, Muhammad? No?
We have one on the shoulder
Yeah?
and another one on foot, diabetic
Okay.
foot.
Diabetic foot.
Yes.
Okay. So again, I would like to warmly welcome all the Italian society, and Dr. Giuseppe will represent the Italian society in this webinar. I think that we can start on time if you want. The moderator is the coordinator is Dr. Youssef Othman, and the moderators are Dr. Anis Teborbi, President of Tunisian Society of Sports Medicine, and Dr. Mahjoub, who is the leader of Shoulder and Elbow Surgery Group of Tunisian Society of Orthopedic Surgery, and
Bravo.
Dr. Giuseppe. So you will be three moderators. And pleasure to have you can act the moderators. We'll start
Thank
by
you.
which case?
Thank you, Dr. Bouzidi. So, hello everyone. I wish you have a nice webinar. I quickly share my screen to view with you the program of this webinar. So I'm glad to receive our special guests, Dr. Ramzi Bouzidi, the SOTCOT president, and Dr. Alberto Momoli, past president. We will have as an expert panel, even experts in shoulder surgery, Dr. Anis Teborbi, the Tunisian Society Arthroscopy and Sport Surgery president, Dr. Sabri Mahjoub, who is the coordinator and the leader of the study group for elbow and surgery and shoulder surgery, and Dr. Giuseppe Porcellini, who is the head of the Sassuolo Hospital and a professor, associate professor in the University of Modena. So this is our program. We have 6 clinical cases. We will start with Hisham Abid. He will present to us a case of dynamic anterior stabilization. And then Professor Porcellini will talk about managing rotator cuff instability. Sofiane Berzotti will present
We can hear you, Dr. Othman.
Votre micro, c'est Othman. Votre micro, c'est Othman.
Youssef.
Maybe we lost our moderator. Maybe we can move to the first case. We can move to the first case, Hisham Abid.
Hisham Abid.
Okay, I will share my screen.
You hear me? So
yes,
just and reminder everyone, you try to mute your mics during the presentations. And if you have questions, we can ask them in the chat, and I will transmit them. So Hisham, you may.
Okay, can you see my screen?
Yes.
Okay, so we are going to talk about dynamic stabilization. Our case is about a patient, 27 years old. He's an active patient who goes to the gym. He had 4 episodes anterior shoulder dislocation, right shoulder. On the physical examination, apprehension and relocation tests were positive. Sulcus was negative, and we had no signs of hyperlaxity. You can see on the right the X-ray AP view. Nothing to say. And so we are. It's a case of anterior shoulder instability. On the right, we can say it will be the Hill-Sachs lesion and a Bankart lesion with the region of the anterior inferior rim of the glenoid. And unfortunately, we don't have the CT scan nor the arthroscan images. So we have a glenoid bone loss inferior to 20%, and the humor is on track. Here we can see the arthroscopic view of the shoulder. Here is the Bankart lesion with the abrasion of the glenoid rim and the Hill-Sachs lesion here. And we can see that the humerus stays on track. The Hill-Sachs lesion stays on track. Okay. So we are in this intermediate group. We have glenoid bone loss, which is inferior to 20-25%, and an on-track Hill-Sachs lesion. The solution for this intermediate group is dynamic anterior stabilization. So dynamic anterior stabilization is a biceps tendon transfer It permits sling effect without bone augmentation and without disturbing the muscular environment, especially for the pectoral spine. The advantages that is an arthroscopic procedure. It does not require screws. We do not have problems of graft overhang, and it avoids cellular dyskinesis. So the operation is performed in the beach chair position without traction under general anesthesia. We use an undo button. We do not use screws, and we do not perform a labral repair. So initial exposure on the step 1 and portal placement. So an intra-articular approach is used through a standard posterior portal. Anterolateral and anterior portals are then established by an outside-in technique using spinal needle as a guide. And as we can see in this video, we start with the opening of the rotator interval. So here the rotator interval is free. And we can move to the next step. Next step is long head of the biceps liberation and addressing. So as we can see, the bicipital groove is opened laterally and distally to avoid detaching subscapulars. You can see the liberation of all the bicipital groove. And when the long head of the biceps is free, we can move to the next step. The next step is the subscapulars split. So for this split, two options exist to create the split either in the middle of the subscapulars or on the 2/3, 1/3 junction. Somebody is drawing on the screen, it's not me. So here we can see the split of the subscapularis. From a lateral viewing portal, a switching stick can be passed across the glenohumeral joint through a posterior approach at the level of the inferior glenoid. The switching stick is now found on the retrocoracoid space and maintained lateral to the conjoint to avoid damaging the nerve plexus. The probe is finally introduced through the anterior portal to complete the split. And then we can move to the next step. Step 4 is the anterior glenoid panel drilling. So a drill is used to prepare a hole from the anterior to posterior within the neck of the glenoid and through the subcapillars split, as you can see on the video. Okay, when that is ready, we can move to the next step. It's biceps transfer. And we can see that the long head of the biceps tendon is passed through the subscapular split into the pre-drilled hole to establish the sling effect. And then we can move to the long head of the biceps tenodesis to anterior glenoid. We can see the passage of the undo button through the hole and the fixation of the long head of the bicep. And this is the final arthroscopic view, visualizing the long head of the biceps tendon in front and back of the subscapularis, demonstrating the sling effect of the tendon over the subscapularis. Post-operative X-ray with the undo button. For post-operative rehabilitation, is kept by the patient for 2 days. Passive mobilization can start on day 1. We do not permit elbow active flexion against resistance for 6 weeks, and return to sport is allowed at 3 months post-operatively. At the last follow-up, which is for our patient, we have a good result, no recurrence of inflammation. We have a complete range of motion to his sport activities, and he is satisfied. So this technique got satisfactory results at 2 years post-operative, as showed in this study, and more recent articles are appearing. And thank you.
Many compliments. Many compliments. May I perform some question?
Yes, of course.
I appreciate a lot because your video, the quality video, the technique is very clear. And, indication probably is right, but I have some doubts. Of course, I am studying this technique, but I have some doubts about one, the quality of tendon, because of course the principle is the same of Lagé, but the joint tendon is very large. The biceps is different, and the quality of fixation. Of course, the problem in Lagé are but the button probably is a very good idea, but if you have just one button, probably is for stability is enough. This is my doubt.
Yes, we tried this technique with the screws, but we had problems at the placement, which is very difficult of screws, and do not have the our country as the technique by Colin and Lederman. That's why we find it preferable to use on the button.
Yes, and the doubts are biomechanical because in lateral a very large tendon is enough for biceps.
For now, yes, we have good results, and the studies are going on. So
good.
We are watching.
Yes, of course, but many compliments for the video.
And Dr. Giuseppe, what would be your idea if this technique was associated with either labral repair, for an example, or with a remplissage? Would that be be a better association in order to have better stability at the long term, either than doing the DAS by its own?
Yes, very, very good, because a remplissage in this case for me is mandatory, because of course after 2 years is a good result, but when in the future you perform a long follow-up, the is only about the biceps. Is enough? I don't know. So if you perform replication posterior, is a good option to remain the humeral head stable in the articular space. Yes, I agree with you.
So there is a question in the chat room. Dr. Kamal Abdul Haq, is there a long-term results to follow up for this and recurrence after?
For now, Colin and Lederman, who did the technique, are studying the results. I think they have 4 years of follow-up on their last study, and we are still waiting for
It's
further
not
results.
enough. It's not enough. We will wait. It's not
Yes,
enough.
for sure.
Hisham, can you unshare your screen so that
Yes, of
Professor
course.
Giuseppe can share this?
Yes.
Okay. Share the screen.
Oh, there is another question. If you can answer. Waiting the sharing screen.
Dr.
Yeah.
Abdullah is
Question
asking,
in the chat room.
at which time can we start the full range of motion post-operation?
For passive mobilization, we can start immediately, and for active, we start around 3 for 6 weeks after post-operatively.
It's okay.
Okay, I think we can start with Professor Porcellini and the present.
Do you see the video?
Yes.
Okay. So, aiuto. Perché non... questo che dobbiamo fare. Okay. The first case, male, 32 years and a professional pilot. Do you see the video?
Yes.
Yes.
This is a very famous Ducati pilot and arrived in Clinica Mobile with in the circuit medicine emergency with instability and of course is a polytrauma. And this just is a just instability. After reduction, the pilot went on and go on with the pain, and so is it performed an MRI, and this is an MRI with associated calf tear, a supraspinatus tear. So this is a clinical examination of a lot of local pain, range of motion reduction, not only apprehension and fear of instability, but job test 3+, Gerber test, and Napoleon test is difficult to evaluate for a subscapularis lesion. But which treatment instability and calf. In Italy, is a long debate about to treat instability, only calf, only repair, or bunker plus rotator cuff repair, and subscapular management. Only rehabilitation protocol, because sport medicine in Italy is very difficult to decide, because the manager, the high level interest, so the athletes decide not only for the show, but for the money, of course, and with one case. The second case, just to evaluate the difference. This is a female, 31, spiker in cap of volleyball player national team in Italy, dominant arm, and not instability, but pain in the shoulder. It's painful shoulder. So the history was strong pain in anterior and mid part during the attack in the volleyball, inability to move the arm or feet, like a dead arm, no straight, and pain in the night after the match. This is a test, of course, not only instability test, but test of job test and scapular muscle weakness, and dyskinesia type 2. What about MRI? Instability with sovraspinatus tear. But pay attention to capsule. Is difficult to discover a lesion of capsule in the humeral head side. The name is Agol lesion, and when I try to explore this image after the arthroscopy, now very clear with the bunker lesion is Agol lesion. So which treatment? Conservative, bunker capsular repair, Latarjet, rotator cuff repair, capsule plus rotator cuff repair, or only rehabilitation protocol. But of course, these athletes has performed 4 months of physiotherapy. So and performance. So this was the first case. I treat the Bankart with the 3 old suture anchor, but I treat the suture of the calf with metallic anchor. And this is the 3 years of follow-up. Good range of motion without apprehension and good strength of sovraspinatus. Second case, instability, but look, you can discover in this video a Agol lesion, but in V shape lesion, not only detachment from humerus, but in a V-shaped manner of the lesion. So was easy to close the capsule with one PDS and one suture tape and Bankart lesion, like this and like this. I treat both the sovraspinatus tendon tear, and this is the closure with a suture metallic anchor. So the debate is a volleyball player. So stiff shoulder was the main complication of this procedure to treat both. But in this case, after 3 weeks of mobilization, we recover the full restoration after 8 weeks and with exercise. We called the patient after 4 years of follow-up, and the athletes continue and go on with his sport. Thanks you for your attention. Okay.
Thank you, Dr. Giuseppe, for these very, very nice cases, very complicated cases, decision-making difficult. Considering the second case, the volleyball player, would you have considered doing another procedure than the capsular reconstruction if she did some other type of sports? I mean, was your concern the loss of external rotation, which can happen after a Bankart with remplissage, or which can happen after a Latarjet, and that's why you went to this capsular repair?
Yes, I remember 2-3 cases. If it's not possible to suture the capsule, because remember, micro instability. This is a case of micro instability with pain, not with frank instability. The patient arrived in my office with pain, not with a feeling, just a feeling of dead arm. So Latarjet, in my clinical experience, was exaggerated. So the problem was the capsule, because in this case I was very, very lucky, because I closed the capsule and I fixed posterior cord of the calf to recreate a stable shoulder. But sometimes I perform Latarjet anterior, but in some cases I prefer the transfer of latissimus dorsi if the posterior superior calf is reparable, to recreate the stable shoulder. So it's difficult, because sometimes orthopedic in Italy thinks instability and calf, two separate surgery. But in this case, I want to offer your experience about share the instability with the calf. So it is mandatory to treat, in my experience, both.
And in the first case, that was a full thickness acute tear.
Yeah.
But if you had like that, in the second case, if it was a partial thickness,
yeah,
chronic tear, would you have treated it? Because rotator cuff repair will also, you might have stiff shoulder and she'll no longer be able to throw correctly. So do you differentiate it?
Yes, yes. Of course, traumatic in this case. And the second case is I want to reinforce the posterior cord, but is degenerative cord. So is the risk of stiffness for the second case was bigger. Yes.
So, Dr. Giuseppe, what is your experience with this Hegel lesion? Do you treat all of them arthroscopic or do you treat some of them open?
Very, very interesting case. A lot of case when I discover algal lesion in chronic, I prefer to perform Latarjet. I don't trust in the chronic shoulder algal lesion with the suture. In acute case, I prefer to treat with a suture anchor in the humeral head, but it depends of elasticity of the capsule, because I try to report the capsule in the humeral head.
Okay.
And these Hegel lesions, they're not very easy to diagnose. Do you have any clinical exam that will orient you to this type of lesion, or do you have a very good radiologist, or do you do them for yourselves?
Good, very, very good question. A lot of Hegel lesion I recognize during arthroscopy. This is a reality. But I adjust a trick in the clinical examination, because Hegel lesion, the patient has just a small apprehension, because proprioception and mechanical reception in Hegel lesion doesn't exist. So the patient in abduction external rotation doesn't have apprehension, because the capsule has not a tension for the apprehension. Good question.
So do we have any questions from the floor?
I think we can move to the next case.
Thank you. Thank you again.
Grazie mille.
Thank you.
Hello, everyone. So I will present to you a case, clinical case on shoulder instability. So it's a case of a 19-year-old girl. She's epileptic, non-epileptic under treatment. She had idiopathic scoliosis and psychiatric history with a suicide attempt. She had a loaded history. She had countless anterior dislocations of the right shoulder with a lot of voluntary dislocations. She manages to dislocate and to reduce her shoulder by her own. So she, on June 2021, she presented to us after trauma. It was a fall on the right hand, but the mechanism of the injury was not well specified. She said it was 3 weeks. She said it was 3 weeks after the trauma, but it could be more. It was considered as an inveterate dislocation. This time she couldn't reduce it on her shoulder, and it was considered as a locked dislocation. So it's a case of a voluntary dislocation that became involuntary. We obviously asked for a CT that showed the anterior position of the head, the large bone defect on the head, a large Hill-Sachs lesion of 3 centimeters, some interarticular fragments. The three-dimensional CT showed the large bone defect on the humerus, the large glenoid bone defect, the bone loss on the anterior rim of the glenoid. So the large defect was not only on the humeral head, but also on the glenoid. And there was a bone condensation, the scapula testifying to the countless anterior dislocations. And there was no evidence on the CT of posterior dislocation of the shoulder. So we decided to operate. It was slightly difficult to approach a dislocated shoulder. We used the deltopectoral approach with the subscapularis split. And we found a lot of damage to the cartilage of the head, a laxity of the capsule, and a highly unstable shoulder. So we've done an open reduction where we decided to do a lateral procedure. We took a large coracoid graft that was also used as a glenoplasty to cover the glenoid defect. It was fixed on a like position with 2 screws, and we completed with the capsulorrhaphy. The patient did not come back to the follow-up. She was lost of sight, and that was the only postoperative radiograph that we had. And 6 months later, she had a car accident, and she came to us with trauma to the same shoulder, causing a surgical neck fracture, without causing a dislocation, without causing a fracture to the glenoid, to the coracoid graft. And she has no recurrence of the dislocation. So we decided to treat with immobilization using a sling. And this is the radiograph after 3 years, showing the malunion of the proximal humerus, and there was no recurrence of the dislocation of the shoulder. At the last follow-up of 3 years, 6 months, she had a good range of motion. She was pain-free. There was no recurrence of the anterior dislocation of the shoulder, and she was clearly happy with the results. Thank you.
Many compliments, Sofiane. Just 2 questions. In Italy, I have 2 cases of the breakage of the screw because the young patient didn't forget to take the drugs. So the problem in epileptic is the screw, the breakage of the screw. The second problem is the limit of the Hill-Sachs, because sometimes in epileptic is not enough Latarjet, and the best indication is Eden Ebinet, the graft of iliac crest. Which is your approach to epileptic patient?
So usually with the epileptic patients, we have posterior dislocation. But in this case, it was an anterior dislocation because it wasn't caused by epilepsy. But under treatment, it was stabilized. So there was no epilepsy crisis. So in this case, we treated as a normal non-epileptic dislocation of the shoulder? This is for the first question. And for the second question, in epilepsy, we use the adenobinate, the iliac crest, because it's more stable and there is fewer risk of recurrence of the dislocation after and the breakage of the screws. But in this case, she had an history of epilepsy, but there was no more epilepsy. This case was a case of we usually don't operate these voluntary dislocations, especially with a psychiatric history. But in this case, we didn't have the choice because she came with an inveterate and the locked dislocation of the shoulder, and she was young, 19 years old.
Very good. I appreciate.
Dr. Giuseppe, did you ever consider, like, if you have very large anterior defect of the glenoid and large hill sacks, doing adenobinate associated with a lethargy? You put the iliac crest and you reinforce with the coracoid and the tendon.
Is an option, but I have just a trick. When I perform adenobinate, I increase the size of the graft. So to avoid off-track and on-track very big enlarge. But if you think is not enough, why not? But I'm not experienced about both of treatment.
And when would you consider doing another procedure? This is a type 3 fracture sequela for the ball classification. So when would you consider doing arthroplasty? Is it the age? Is it how long let's say the position has been locked? When would be your cutoff to do open reduction and to go to another option?
Good question. Of course, we are speaking about the not the instability, but anterior locked dislocation. So my approach is how large is it sucks, 50% or less. Another good point is the time. After 1 year, I don't think is a good idea to perform graft and to try reduction because the quality of the cartilage is not so good. So I remember I published in young person is pyrocarbon and reduction in EMI or in old people reverse. Because in Italy, I have experience about the people from the south of Africa with a young person of locked dislocation for, of course, not a good health care. And in young person, I apply pyrocarbon humeral head.
And did you have any dislocations with the hemis? Because when you do for posterior dislocation, it's generally stable, but you have more risk of redislocation when doing anatomic prosthesis in locked anterior dislocations. So do you have any tricks to avoid dislocation? And how do you manage the subscapulars after 1 year of a dislocated shoulder?
Yes, good question. But I don't release the subscapularis in the tendon, but I perform a flake osteotomy and I reinsert in the same manner. but to avoid the anterior dislocation, I perform plus pyrocarbon plus Edenbinet in some case, because of course the erosion of the anterior part of glenoid is too big, and the elasticity of subscapularis is a problem, but I don't touch the subscapularis. I don't like, in my institute, old institute, Rizzoli in Bologna, the Putti-Platt was a classic in instability, but if you if you become short the subscapularis, you create another reason for the pain and for stiffness. I don't like to touch subscapularis.
There is a question in the chat room for Sufyan. Dr. Abdul Khaliq asked about if there is a history of posterior dislocation for this patient, and how did you manage the rehab protocol after the surgery?
In this patient, I haven't precised that. At first, we thought maybe the patient had an hyperlaxity, but there was no evidence in the clinical exam of hyperlaxity of the patient. If she had hyperlaxity, then it will be possible to have the same anterior and posterior dislocation at the same time.
What about the rehabilitation program, Sufyan? They asked you, what about the rehabilitation program after surgery for this patient?
The rehabilitation program after surgery, in this case, we retarded the rehabilitation program. Usually, we begin in the first week the rehabilitation program with passive movements, then active movements, proprioception, and so on. In this patient, because she had a psychiatric history and she was not cooperative, we began the rehabilitation program after 14 days.
Okay. Can move. Next case, so Youssef.
So the next case, Sufyan, could you please stop sharing the screen? And we will see the case of Wajdi Arfa, a pediatric case of anterior instability. Wajdi, are you ready? Wajdi?
He's not hearing you. You can go to the next. And,
So Mehdi Bilal, are you ready to present your case?
Yes, of course.
I think we will go with Mehdi, and then maybe we will see the case of Wajdi Arfa.
Wajdi is now in the room. Huh?
Wajdi will be next.
Everybody.
Okay.
In this case, we will see how to manage a failed target procedure. We are in 2016. It's a 29 years old male, right hand dominant. He's a manual worker, and he has having epilepsy under anti-epileptic medication. He dislocated his left shoulder 2 times during a seizure last year and prior to presentation. So we have AP X-ray when you can see dislocation of his left shoulders. So on his physical exam, we can find a significant appreciation in abduction and external rotation. We have full range of motion and the rotator cuff seems intact on testing. The neurovascular exam was normal. We make another AP X-ray in external rotation and in internal rotation. We don't really see a Hill-Sachs defect or Bankart lesions. So, do you need any other imaging to give the management? For us, we haven't another imaging and what we can, how we can manage these patients. So we cannot choose operative management, soft tissue procedure like a Bankart, arthroscopic Bankart, lethargy procedures, or free bone block. Even when we see the instability severity index score, when we calculate the score is 2, but we was afraid from his epileptic antecedent and we make the lethargy procedure with a good initial result. This is the post-operative X-ray. So he came back 1 year after in 2017 with a recurrence of an anterior dislocation. He breakage the screw and we can see that there are migration of the bone block. We can see in the X-ray that there are Hill-Sachs defect here. We make a CT scan and we can see the lesions of the coracoid graft and the torsion of the screw. So now how we can manage our patients. So if you can choose a soft tissue procedures, free bone block, remplissage, or perhaps someone have another procedures to do. If we see this algorithm to treat patients, published in the effort in 22 and published again with Cristina Delgado, we can see that we can choose a free bone graft. And that's we had to do. We take crest iliac graft, a big crest iliac graft, and we do the Eden-Ibinet technique in 2019 after stabilization of his epilepsy with a good initial evolutions. And they are the X-ray, post-operative X-ray. So everything was okay until 2022, and he make again another commissional seizures, and he come back with debridement of the material, the partial release of the iliac bone graft. Here you can see in the arthroscan the partial release of the graft, a big Hill-Sachs notch and bony Bankart. This is the arthro CT scan. And here you can see the last follow-up. It was the last week with the last X-ray and the examination of the patients. We see that he don't have really appreciation, but he feel that he have some chronic pain after some, when we work a lot because he's manual worker, and some days he have a little bit pain on his shoulders, but he have feel any apprehensions, and you can see that you have a good range of motions. In the X-ray, you can see low grade of arthritis. So, any suggestion for the next step? And thank you.
Good, very good case, and it's difficult to foresee the next step because, of course, the patient has in the follow-up high risk of osteoarthritis, but next step is to follow the patient and without, of course, any episode of seizure, and to avoid, of course, to treat osteoarthritis, because in this type of patient it's very difficult to decide the type of prosthesis. Probably pyrocarbon.
For us now, we say to the patient, we will wait and see the futures, but
yeah, it's good.
Still young, and for now it will be okay. But in the next year, we think that we will have osteoarthritis of her joint, and we will have to manage one day.
I agree.
What would you do in case of osteoarthritis, Dr. Giuseppe?
Pyrocarbon.
Pyrocarbon.
Now I have a great experience about mini stem with pyrocarbon to avoid the glenoiditis in this difficult case and very young patient. I prefer EMI with pyrocarbon.
And with pyrocarbon, do you resolve the problem of instability? It can still be unstable with the pyrocarbon.
No. Is probably is my purpose is to eliminate the pain, not for stability. Because in the future, the follow-up probably is osteoarthritis with stiffness and pain, not for instability, of course.
Okay.
And in your experience, what are the other modes of failure of the Latarjet procedure or the Eden Hebinet? I mean, if he was not an epileptic, what would cause the failure? Was it the lysis of the graft, for an example? Would that be a failure?
Yes. The size of the graft, the first, the position of the graft, and the lysis, of course. But the problem is another problem is the amount of heel sacs and the size of heel sacs, because when you have a very big heel sacs, probably the rim rent, the pressure in the anterior part of the glenoid is too big, is bigger. So the lysis, in my experience, increase. Probably in this case, I remember one case I treat both in open. A humeral head graft, allograft for the heel sacs, and head and binet with autograft iliac graft in very, very difficult case.
But for an example, this patient, his ISA score was 2. Do you use the ISA score? Is that for your decision making in your everyday practice?
I'm very honest. I discuss with Pascal Boileau about ISA score, and if you apply ISA score, you don't perform in nobody cases arthroscopy, because it's very difficult to have a low grade of ISIS 1, 2, 3, and so is useful, but just for the risk of instability open of Bankert. But in this difficult case, both of the lesion, heel sacs and anterior glenoid erosion, is difficult to quantify, and because I remember in United States, Anthony Miniaci performed his a metallic surface prosthesis in heel sacs to avoid a pressure in anterior part in head and binet. If you remember the arthrosurface prosthesis to cover a big heel sacs, like a button, metallic button.
Yeah. There is a question in the chat, Youssef, I think.
There is a
no?
question in the chat. I think the discussion answered the most of this question, but I will transmit it. So Dr. Abdul Khaliq asks, is he a candidate for hemiarthroplasty or total arthroplasty since he is young?
Dr. Giuseppe answered already
now.
this question.
Yeah.
In this case, only solution is hemi.
Hemiarthroplasty, okay.
Another question in case of, so because we have international audience today, so we are asking in cases of if prosthesis is not available, are there any other solutions to treat such patients? This is a question from Dr. Awas.
Well, if he's young and he has very severe osteoarthritis, if you do not do a prosthesis, there's not many other solutions, or you do arthrodesis.
Yeah.
Okay, so I think we can move on to next case with Wajdi Arafa, who is now ready to present.
Thank you. Did you see the screen?
Yeah.
Yeah.
So thank you, everyone. Please allow me to present this clinical case. It was about a 16-year-old boy with no previous medical history who was a boxer and who consulted us with anterior instability of the left shoulder. The first post-traumatic episode had occurred 1 year earlier at the age of 15, and since then the patient has complained of recurrent dislocation of his left shoulder with required reductions in the emergency department. In physical examination, the mobility was preserved, and the aspiration and circus test were both positive. But what's important to note that the patient was even able to subluxate anteriorly his shoulder at the time of examination, as shown in the picture. On the other hand, an electromyogram was performed to search for a neurological cause, but the results were without abnormalities. Added to this, the exam of the right shoulder was perfectly normal and no signs of hyperlaxity were found. On X-ray, in neutral, internal, and external rotation, no obvious bony lesion were found, but as can be seen on the X-ray on the left, on the right, when the patient voluntarily subluxates his shoulder, the glenohumeral arch became disharmonious and also produces a subacromial depression, which was perfectly in line with the clinical aspect we saw earlier. On shoulder arthrography, capsule distension was clear as reflected by axillary recess enlargement, and there was no contrast product leakage. The arthro CT scan also revealed capsular distension as an intact rotator cuff and the absence of glenoid dysplasia. No bone lesion were also found. Our therapeutic approach was primarily functional. We prescribed intensive rehabilitation for the boy and education for both the patient and his parents. So the boy would modify his sport activities to avoid dislocations position, but most importantly, to avoid voluntary subluxation movement. But unfortunately, after 1 year of functional treatment, we still found ourselves at the starting point and no involvement was noted. In fact, the patient has a particular psychological profile Moreover, he didn't modify his sporting activity. He continued boxing as before, and he didn't stop making the voluntary subluxations movement despite well-managed psychotherapy, and his therapeutic request was to give him a radical solution for the instability of his shoulder that affected his life. Given the failure of functional treatment, the indication for surgery was retained after a long hesitation, and the boy underwent a capsulorrhaphy and lethargic block procedure. This video clearly shows the capsular distension and the resulting laxity, especially inferior. The purpose of adding a lethargic bone block to the capsulorrhaphy for this patient, despite the absence of bone lesion, was to minimize the risk of recurrence, and we wanted to do a single surgery to resolve the problem, given his particular psychological profile. And here, on the left, is the postoperative X-ray. So fortunately for him and for us also, there were no postoperative complications. The boy was immobilized for 45 days, after which rehabilitation was started. At the last follow-up, at 18 months postoperatively, the shoulder was still stable, and the deltoid muscle had regained its usual tropicity. Shoulder mobility was complete and pain-free, and he resumed boxing after 1 year postoperative. So the question that always arises is whether to operate on children with habitual shoulder instability, like this article by Tristan Longley and his colleague who have reviewed the literature. There is no here or no question answer, but the essential thing is not to overlook certain points, such as the search for etiologies like ligamentous hyperlaxity, neurological disorder, and above all, psychological disorder. Treatment is usually functional, but it's if it fails, and especially in the case of gene damage, surgery is indicated. And thank you.
Many compliments, very interesting case, but in this case, probably the psychological approach was the best solution to treat not only with the surgery, because in Italy, we have a lot of adolescents with the problem with the parents, with the voluntary subluxation. The first question is apprehension plus involuntary is very rare, because involuntary, in my approach, in my clinical experience, doesn't exist apprehension, involuntary subluxation. The first question. The second is, which is your approach with your physiotherapist? Is balance of the muscle, or because in Italy, in Modena, in university, we try to approach with a new electrotherapy to find a good solution. Which is your approach for physiotherapy?
Thank you for the two questions. First of all, for the apprehension, it's very, very rare, as you said, and we don't have explication why this patient have apprehension and voluntary instability. For the second question, we prescribed balance between the deltoid muscle and the calf muscles to avoid the co-contraction phenomenon who lead this probably to this voluntary subluxation of the left shoulder.
Very good.
We have a question from the chat room. Dr. Ben asks, did the patient had scapulohumeral dyskinesia? these cases?
No, we didn't note that abnormality in the physical exam.
I have a question for our experts and for Wajdi. Is there any particularities to keep in mind when treating a child with shoulder instability?
Yes, the most important message is to look always for an etiology, like anal Danos pathology or Marfan pathology, who accompanies with the hyperlaxity for capsules and ligaments. This is the first thing for the diagnosis, and for the therapeutic approach. Always do functional therapy in the first and the gold standard in these cases. Surgery remain the second choice after the failure of all psychological therapy and physiotherapy. For the techniques, there is no consensus in the literature because it's a very rare pathology, especially in children.
And Dr. Giuseppe, do you have any experience in, I know we do not do it anymore, in shrinkage of the capsule that for these hyperlax patients? Do you have any experience about this?
No, but in my fellowship in United States and in England, the Professor Copeland and Ofer Levy applied this technique, but is very, very dangerous now because create a chondral lesion, and I don't support this technique because create a chondral lesion. So plication is of capsule is failed in the past. So the best solution is Latarjet, and capsulorrhaphy is a wonderful case presented by colleague, but the instability, voluntary instability is very, very dangerous.
Dr. Ali Say from the chat is asking, is there a difference between habitual dislocation and voluntary dislocation, or are they the same? This is a nosology question.
Absolutely not. Habitual is a dislocation in post-traumatic or in laxity. Voluntary is the patient voluntary with his muscle create instability. But there is another form, laxity outside, and voluntary with the muscle, you create a stabilization. And so it's very difficult sometimes to evaluate this patient.
Okay, thank you. So I think we could move on to the last clinical case with Rasim Gidara, who will talk about posterior instability. Meanwhile, just the last question from the chat, Dr. Naha Ammar, after how long of physiotherapy we are talking about a failure? We may say there is a failure.
1 year, in my experience.
Hello, everyone. So this case is about an 18 years old football player, right-handed, who suffered from right shoulder instability since 4 years. You can see in this video how he can dislocate his shoulder posteriorly. He had no pain, but this instability has a functional impact with feeling insecure and uncomfortable. This is X-rays of our patient. And we can see the difference between the horizontal morphology of the posterior acromion of our patient in the right side and angular morphology of another patient shoulder X-ray in the left side. The acromion of our patient is also higher located compared to the left one. Gerber showed in this publication that posterior acromial morphology is significantly associated with posterior shoulder instability. CT scan with articular injection showed a posterior glenoid bone loss, a posterior glenohumeral subluxation with remarkable retroversion of the glenoid. This is the CT scan of the left shoulder. We calculate the retroversion of the left shoulder without instability. It was only 2 degrees, but the right one was 20 to 22 degrees, so it was very retroverted, and that exposed to the posterior instability shown in this patient. New CT scan was performed, and we can see the retroversion of the glenoid dysplasia, and the posterior bone loss. The posterior acromion had an horizontal morphology. In this CT section, the retroversion was calculated. It was 22 degrees. So, how to manage this situation? We decide to correct the glenoid retroversion by an extra-articular glenoid posterior wedge opening osteotomy, and we associate a posterior bone block. As it was shown in this review article, glenoid retroversion can be addressed with an opening wedge glenoid osteotomy. Posterior approach was done. After skin incision, we make a deltoid split and we pass between the infraspinatus and the teres minor to get access to the posterior side of the glenoid. We discover a para-articular cyst between these two muscles that was removed. An extra-articular osteotomy was performed in accordance with the surgical planning. An iliac bone graft was intercalated in the opening wedge to maintain correction. Another iliac crust graft was used as a posterior bone block of the glenoid and was stabilized with 2 screws. These videos show a good stability of the scapulohumeral joint. Postoperative X-rays showed a good positioning of the bone block. The shoulder was immobilized with a splint maintained in neutral position during 6 weeks without rehabilitation. That was our functional results 4 months after surgery. The new CT scan showed the correction of the retroversion from 20 degrees before surgery to 2 degrees after surgery, like the contralateral shoulder. Positioning of screws was correct, extra-articular, and 3D view confirmed the good positioning of the posterior bone block. In literature, another case with horizontal acromion and joint subluxation was published recently by Gerber. Preoperative X-rays showed the horizontal morphology of the acromion. The management associate an acromial lowering osteotomy with an extra-articular posterior wedge opening osteotomy of the glenoid to correct the exaggerated retroversion. In conclusion, posterior shoulder instability is a rare pathology. In this case, the glenoid dysplasia with the exaggerated retroversion are accused to be the source of all problems. Management associates a posterior glenoid opening wedge osteotomy with posterior bone block that can be done with arthroscopy if we have the expertise to do it. Thank you.
Many compliments, very, very difficult case. I appreciate the technique and the quality of the surgery. Many compliments. My ideas is I have some doubts about osteotomy. I appreciate the research of Christian Gerber. But osteotomy of the acromion is difficult to do and to image. Posterior bone block and the idea of osteotomy, in Europe there is a rash technique in Austria, is a good way. In my experience, I perform a posterior bone block in arthroscopy with the LaFosse tools and capsulorrhaphy, but a good doubts about retroversion. So the osteotomy is another good point. Many compliments.
Dr. Awas is asking, what is the most common complication of this technique?
I think if we respect all the techniques as it was described, we have always no complications, because we pass in a secure interval between teres minor and the infraspinatus muscles. So after doing a split of the deltoid, so we usually haven't complications.
It's not a usual technique. We have to say also that osteotomy, extra-articular osteotomy of the glenoid block bone, is not easy to do. And we have to plan exactly the orientation of the osteotomy, and we have to plan the open wedge osteotomy exactly, because if we lose this stability, the anterior stability of the glenoid neck, it will go in all the directions, and we cannot stabilize, we cannot fix the osteotomy. It's not easy when we are talking about a difficult technique, so complication can happen. It's not a common technique.
So absolutely, Dr. Ramzi.
Yes.
So planification is the key of having good result. And actually, I think that the 3D impression can be helpful for this planification to have an exact positioning of the bone block, and so good results.
And Dr. Giuseppe, when you do a posterior bone block, how do you position the bone block? Do you want it to be flush? Do you want it to overhang, or to be a little bit more medial? How do you?
Yes, a good question. But in arthroscopy, it's very easy to apply because I perform with LaFosse and tool, but the problem of this technique is key wire anterior. I have one case of pneumothoracic because key wire go into the pleura. So pay attention about this technique. But a second is your question about I prefer in posterior flash because I want to recreate a glenoid surface and I perform capsuloplastic not in the graft outside, but in original position of glenoid labrum, posterior glenoid labrum.
This is a very complicated case, even for diagnosis. Before surgery, the difficulty is starting from the diagnosis, and you have to call to mind the possibility of exaggerated retroversion. And then the operative technique, which is not as easy as usual.
Okay. Sabri, Anis, would you have something to add? Youssef?
No, I think it's very good, very difficult surgery and rare cases of this type of surgery. So it is some anecdotic surgery.
Okay, Youssef, yeah, it was the last case?
It was the last case, and wonderful cases that were presented here with a very distinguished panel of experts. I thank every one of the audience. We had audience from many countries today. I will not name the countries because I can't call them all, but thank you everybody. I will just present here the main messages for each case, and then please stay connected to the end because we will perform a photo of the group. So I'm sharing my screen now. So we had six nice cases today. With the first case of Hisham Abid, we see that when Bankart is too late, lethargy is too much, we can think of dynamic anterior stabilization. Professor Porcellini presented two cases that show that it is important to manage the calf lesion in patients with instability. We usually think to the calf when the patient is old, but we saw that it is also important for young patients, for athletes. With the case of Sofiane Benzarti, we saw that when we are managing a locked dislocation, we have to pay attention that we will be confronted to bone losses that we should treat in the same time, so we have to be prepared. With the case of Mehdi Belid, we saw that when we have an instability for epileptic patients, you have to ask the help of neurologists first. The case of Wajdi Alpha showed that for pediatric patients, we have to always seek for the etiology, and that physiotherapy and psychological management is very important. The last case of Rasim Gidara show that when we have a posterior instability, watch for the glenoid retroversion. Thank you, everybody. And please, I am asking everybody to share your video so we can perform the photo of the group.
Thank you very much, and many compliments for high level quality of the cases and discussion. For me, was very proud to participate to your webinar. Many compliments.
Thank you very much.
Thank you very much.
Thank you very much, Professor Giuseppe.
Will you please open your cameras for the photo? Thank you.
Ciao, ciao.
Ciao, grazie professore.
Grazie a te, è stato molto bello, complimenti.
Voglio,
Veramente bravo.
I wanted to thanks all the participants to the webinar for our society. The SIOT is very honored to participate in this first webinar. I see that there are 150 person participate, and is very important because it's more than our experience. In our webinar, the participants are less than this Congress, and I hope that is the first one of more and more meeting that we can organize with our ambassador Abdel. Okay, thank you for
Thank you very much.
Thank you, guys.
Thank you, President.
Thank you. See you next webinar.
Thank you for all.
You're always welcome.
Yes. Ciao, buonanotte.
Buonanotte.
Ciao Abdel.
Ciao, Alberto.
Ciao Giuseppe, grazie.
Buonanotte.
Merci. Bonne fin de soirée et à très bientôt, Inch'Allah.
Au revoir.
Bye bye.
Au revoir.
Au revoir.
Merci, au revoir.
Bye bye.
Bonne soirée, au revoir.
Également.
Au revoir.
Au revoir.